Welcome back to the deep dive. Today we are taking on a topic that sits right at the intersection of uncommon presentation and just critical life-altering importance, testicular tumors.
It really is a high-stakes area, and I think
Yeah.
if we're looking for that one single fact that really elevates this, it's this. While testicular cancer is, statistically pretty uncommon compared to, say, prostate or lung cancer,
Right.
it overwhelmingly affects young men. The sources are so clear that the highest incidence is right in that key life stage window, generally between the ages of 20 and 40.
And that concentration in young adults is exactly why this is so crucial. We're talking about a highly curable disease. It's often cited as one of the most curable solid malignancies out there if it's caught early.
That's the big if.
It is, yet there's this sort of jarring failure point in the system. We see these frequent delays, and they're often rooted in, well, low awareness among patients who just dismiss a painless lump.
Or, and this is also key, sometimes an inadequate or incomplete clinical examination by healthcare providers.
Exactly. The dichotomy between this immense curability and the significant diagnostic delay is, I think, something we absolutely have to address.
For sure. So our mission today is really to give you, the listener, a confident, structured, and guideline-based roadmap.
This isn't just about memorizing facts.
No, not at all. It's about building a logical sequence of reasoning. We want you to be able to confidently evaluate a patient, instantly differentiate the likely benign from the genuinely malignant, and know the immediate next steps. This is your shortcut.
That sounds like exactly what we need. So moving beyond just a textbook summary and into that disciplined reasoning, what's the path we're taking today?
We've got to lay out the map first. We'll start with the foundational anatomy, really focusing on that unique pathway of spread.
Okay.
That leads us right into classification and the high-yield risk factors. Then we dedicate some serious time to the clinical history and examination. Those are the steps where suspicion really gets generated.
And after that?
Investigations. The mandatory ones, the absolute rule about biopsies, and then finally, the diagnosis-specific management pathways.
And is there a unifying theme we should be keeping in mind through all of this?
I think it's twofold. Early diagnosis, number one, and number two, maybe even more importantly, correct surgical decision-making. Making the right incision or, not making the wrong one is foundational here.
Let's start with that foundation then, anatomy. I feel like we often overlook the geography of a cancer, but here you're saying it's essential because it dictates where the disease goes first.
That's exactly right. You have to visualize it. So the testes is an intrascrotal organ. It's got a few layers of covering. The most immediate, this tough fibrous layer, is the tunica albuginea.
That's what gives it its shape.
Precisely, its shape and rigidity. Then outside of that, you have the tunica vaginalis, which is basically a remnant of peritoneum that creates a potential space.
Which is where you get fluid collections, like a hydrosol.
That's the spot. And physically, we have to locate the epididymis.
Okay, and where does that sit?
It's right along the posterior, the back surface of the testis. It's this coiled tube for sperm maturation and storage. And its location is so crucial in an exam.
Why is that?
Because most benign masses, they tend to be extratesticular. They arise from the epididymis or other structures.
But
Malignancy is almost always intratesticular. It's inside that tough fibrous shell of the testes itself.
And all of this is connected up through the spermatic cord, which isn't just a rope. It's more like the lifeline for the testes.
It's the freeway. It's got the testicular artery for blood supply, the pampiniform plexus of veins for drainage, the vas deferens for sperm transport, and the single most critical piece for this deep dive, the lymphatics.
This is where it gets interesting. This is the aha fact, the thing that should immediately change how you think about staging. So tell us about this lymphatic drainage and why it's so, well, counterintuitive.
This is the absolute high-yield concept. Because of how the testes develops embryologically, it descends from the abdomen during fetal development. Its lymphatic drainage doesn't follow the local structures.
It doesn't go to the groin nodes.
No. Instead, the lymphatic vessels go way up with the spermatic cord and drain directly to the periaortic lymph nodes, the retroperitoneal nodes.
The retroperitoneum. So that's the deep compartment in the very back of the abdomen.
Exactly. It's that core plumbing compartment right near the aorta, the vena cava, the kidneys, and its location is just fundamental. It means when a testicular tumor spreads, it just bypasses the nodes you'd expect in the groin, the inguinal nodes.
And that's the textbook misconception we have to dismantle, isn't it? The idea that a problem in the groin means you check the groin nodes first.
It's a huge pitfall. The source material is adamant on this. The drainage is not typically via the inguinal nodes.
Hmm.
The only time you really worry about them is if the scrotal skin itself is involved, through a prior surgery or a massive local extension.
But for a primary intact tumor,
The spread is central and deep.
which gives us that perfect clinical reminder from the sources, a testicular tumor spreads to the abdomen before the groin.
That phrase should just dictate your entire diagnostic strategy. If the primary spread is to the periaortic nodes, then your whole staging process has to focus there. You have to order a CT scan of the abdomen and pelvis.
So you're not just scanning the local area, you're scanning the entire anatomical path of spread way up into the back of the abdomen.
Precisely. And this knowledge prevents catastrophic omissions. You can imagine a busy clinician ordering a pelvic ultrasound, maybe a chest x-ray, but forgetting the dedicated CT of the abdomen,
And they could miss massive retroperitoneal disease,
which can be clinically silent, except for maybe some vague, unexplained back pain.
a symptom that suddenly makes perfect sense when you link it to a tumor pressing on nerves in the retroperitoneum.
Exactly. So understanding the why that embryonic descent explains the where of metastasis. It's just a beautiful piece of high-yield anatomy that reframes everything.
Okay, so knowing where it spreads, let's classify what we're actually dealing with. We should start with the type of tumor that is just overwhelmingly dominant here.
Right. The sources are very clear on this. The vast majority, we're talking about 95% of testicular tumors, are germ cell tumors, or GCTs.
So that's your default diagnosis. A mass in a young man, you're thinking GCT.
Assume it until proven otherwise. But GCTs aren't all the same. There are two major categories with, wildly different implications.
And that's the key distinction we need to make.
It is. We divide GCTs into seminoma and non-seminomatous germ cell tumors, or NSGCTs. And this separation is vital because seminomas are typically more uniform, a bit less aggressive, and crucially, very sensitive to both radiation and chemotherapy.
Okay, so that's seminoma, and then you have the NSGCTs, which is the more diverse and, I take it, more aggressive group.
That's right. The NSGCT umbrella covers a whole collection of cell lines that are less differentiated and often more dynamic.
And what are the specific types we need to know about?
Well, there are 5 core types. First is embryonal carcinoma, which is known for being highly aggressive, often growing very rapidly.
Okay.
Then there's yolk sac tumor. This one is notable because while it's raw in adults, it's the most common GCT you see in children. It's also tied to elevated alpha-fetoprotein, or AFP.
Right, one of the key tumor markers.
Exactly. Number 3 is choriocarcinoma. It's rare, but extremely sinister. It's infamous for high vascular invasiveness, so it spreads through the bloodstream early.
Do the lungs, the liver.
Yep. And it produces massive amounts of beta-HCG, another one of our key markers.
Okay, what's next?
Teratoma. This one contains elements from multiple germ layers. You can sometimes even find hair or teeth.
Wow.
And finally, you have mixed tumors. And these are actually the most common finding combinations of 2 or more of the above. And any tumor with any non-seminomatous component is treated like an aggressive NSGCT.
So we don't just list these for academic reasons. The presence of something like choriocarcinoma or embryonal components, that's going to drastically change the management plan.
Absolutely. The aggressive subtypes dictate the management. The key takeaway is really, seminoma is generally the better diagnosis from a treatment perspective, while NSGCT is the more complicated one, often demanding more intense chemotherapy.
And we should just briefly acknowledge the remaining 5%, the non-germ cell tumors.
Right, the outliers. These are tumors from supporting cells, like Leydig cell tumors or Sertoli cell tumors. What's interesting is they often present because of hormonal effects, since they can produce testosterone or estrogen.
But the good news is they're usually benign.
Usually benign and often cured just by the initial removal.
Okay, so moving from classification to the clinical history, the first and most immediate filter is just age. This seems incredibly high yield.
Age creates an immediate diagnostic bias.
Mm-hmm.
If your patient is between 20 and 40, you are locked into GCTs. If the patient is a child or an infant, your suspicion immediately shifts to that yolk sac tumor.
And if we see a testicular mass in an older patient, say 60 or 70 years old,
then the alarm bells sound for something completely different. Testicular lymphoma. This is often secondary involvement. The lymphoma started elsewhere and spread to the testes. It requires a completely different management path, so that age correlation is an instant pivot point.
beyond age, we have to identify the key risk factors. So what's the single most important historical factor we need to ask about?
Without a doubt, it's a history of undescended testis, or cryptorchidism. The sources just emphasize this relentlessly.
Even if it was surgically corrected years ago.
Even if it was. If the test size fails to descend normally, even with a later orchidopexy, the risk of malignancy in that testis is significantly increased.
So that risk factor is never truly erased?
Correct. It remains elevated. You have to ask about it. The next factor is having a previous testicular tumor in the other testis. The recurrence risk is substantial, which is why surveillance is so rigorous.
What else rounds out that high-yield history?
You have to ask about family history, especially first-degree relatives, which points to a genetic link. And finally, a history of infertility or subfertility.
It seems like these all point to a fundamental issue with germ cell development.
That's the thinking, yeah. A condition sometimes called testicular dysgenesis syndrome. They often run together. So a thorough history covering these points helps you quantify your suspicion before you even lay a hand on the patient.
Let's turn to that now, the patient's experience. What brings them in? The most common symptom is actually quite deceptive, isn't it?
It is. The classic presentation, the one that should trigger the highest suspicion, is a painless testicular swelling.
And the word painless is the trap. People assume if it's serious, it must hurt.
Absolutely. That absence of pain is the key to the whole delayed presentation problem. The patient might describe a vague feeling of heaviness or maybe a dull ache in the lower abdomen or groin.
So pain is just not a reliable feature.
Not at all. Its absence should never be reassuring.
That covers the local symptoms. Now, what about systemic symptoms? These are crucial because they signal that the disease has progressed.
These are major red flags. General signs like unexplained weight loss are concerning, of course, but the two most important signs are the ones that track the known routes of spread or hormonal activity.
And the first one points directly to the retroperitoneum.
Back pain. We established the para-aortic nodes are the primary landing zone. When they get burdened with tumor, they form a large mass. This mass can press on nerve roots, leading to this persistent nagging back pain.
Which could easily be mistaken for a muscle strain in a young guy.
Exactly. A hard scrotal mass plus new back pain. You have to assume metastatic disease until proven otherwise.
And the second key systemic sign is gynecomastia.
Right, enlargement of male breast tissue. This is highly suggestive of a hormone-secreting tumor. Specifically, choriocarcinoma produces high levels of beta-HCG.
And that hormone mimics other hormones in the body.
It mimics luteinizing hormone, or LH. In high enough concentrations, it stimulates complex hormonal shifts, including increased estrogen, which causes the breast enlargement. It's a very specific physical finding.
Okay, now to the heart of it. The systematic clinical examination. We need to walk the listener through this step by step.
It has to be systematic. It starts with inspection, looking for symmetry, skin changes, obvious swelling. But the real diagnostic power is in the palpation.
And you're assessing 5 features here: size, consistency, surface, tenderness, and whether you can get above the swelling.
Let's detail the findings that screen malignancy. We palpate the testes, usually with 2 hands, and we compare it to the normal side.
Okay.
First, consistency. A malignant tumor is almost always hard, rock hard. Second, surface. It tends to be irregular or nodular. Third, tenderness. It's typically non-tender, reinforcing that painless presentation.
And the last point is about its location.
Well, this is critical. The mass cannot be clearly separated from the testes itself. It's an intratesticular mass embedded within the tissue.
This combination of hard, irregular, non-tender is the definitive profile. Which brings us to that second essential clinical mantra. A hard testis is malignant until proven otherwise.
That is the gold standard of clinical suspicion. If you feel that, your suspicion should shoot up to 95%, and you initiate the malignant pathway immediately.
Now, let's talk about differentiation. We need to rule out a hydrocele, a fluid collection. This is where transillumination comes in.
It's simple, but definitive. A hydrocele is fluid, so when you shine a bright light through it in a dark room, the whole thing will transilluminate. It lights up.
And a solid tumor.
A malignant tumor, being dense tissue, does not transilluminate. It's a quick and effective screen.
But the exam can't stop there. The source material warns us, never examine the scrotum alone.
That's mandatory bedside staging. You have to assess the abdomen for any palpable masses, which would be bulky retroperitoneal nodes. You have to check the supraclavicular lymph nodes, the terminal stations for advanced disease,
And look for gynecomastia.
and check for gynecomastia. A complete systematic examination is the only way to accurately assign a provisional stage right then and there.
So that systematic exam is designed to narrow the field. What are the key differentials the clinician is trying to rule out?
Well, when a patient has a scrotal swelling, You're systematically sorting between 5 main things. 1, the testicular tumor we've been describing.
Right.
2, epididymoarchitis, that's infection, usually acutely tender, often with fever. 3, a hydrocele, that fluid collection that transilluminates. 4, a varicocele, those dilated veins, often called a bag of worms. And 5, testicular torsion, which is an acute surgical emergency with severe sudden pain.
And once your clinical suspicion is high for malignancy, that hard intratesticular mass, you jump straight to investigations. What's the mandatory first-line imaging?
The ultrasound scrotum. It's the mandatory first step. It's fast, it's non-invasive, and it's there to confirm 2 things definitively.
So far.
First, that a mass is really there, and second, whether that mass is intratesticular or extratesticular. If it's outside the testes, the chance of malignancy drops dramatically. If it's inside, the probability is about 95% that it's cancer.
So once ultrasound confirms an intratesticular mass, our focus immediately shifts to staging, following that anatomical principle from the beginning.
Exactly. The anatomy dictates mandatory staging imaging. We need a CT of the abdomen and pelvis to assess those retroperitoneal lymph nodes.
That's the most common site of spread.
It is.
Mm.
And we also need chest imaging, either a CT or a high-quality X-ray, to look for lung metastases, which are also very common in GCTs.
Okay, now let's talk about the 3 mandatory tumor markers. You've mentioned a couple of them already. AFP, beta-HCG, and LDH.
Right, and these have to be measured before any surgery. They're multifunctional tools that we use throughout the entire journey.
The sources mention a 4-fold purpose.
Yes. First is diagnosis. Certain markers align with certain cell types. AFP is for yolk sac and embryonal. Beta-HCG is for choriocarcinoma. LDH is more a general marker of tumor burden.
Second is staging.
Right. Very high levels of these markers can automatically upstage the disease, even if you don't see anything on the scans yet. It just indicates aggressive behavior.
Third, prognosis.
Elevated markers correlate with a worse prognosis, which means we might need more intensive initial therapy.
And finally, and maybe most importantly, follow-up.
This is their most enduring role. After surgery, the markers should fall. We then monitor them regularly. A subtle rise is often the very first signal of a recurrence, sometimes months before you can see it on a CT. They're our early warning system.
Which is why those 3 blood tests are absolutely non-negotiable.
Precisely. They're integrated into every single step of the patient's pathway.
Now we come to what you called the critical guideline loop, the absolute rule that defines the surgical approach. This seems like the ultimate aha moment.
It is. This is the rule that separates excellent management from dangerous missteps. Biopsy of a testicular mass is contraindicated.
And this is so counterintuitive. I mean, in almost every other type of cancer, breast, prostate, kidney biopsy is the non-negotiable first step. So why the absolute prohibition here?
The conflict is between wanting histological certainty and the overwhelming risk of compromising the natural lymphatic pathways. The primary concern is tumor seeding.
So if you stick a needle in or make an incision through the scrotum,
You risk spilling malignant cells into the surrounding tissue.
and if those cells spill, what is the disastrous consequence?
You instantaneously change the lymphatic drainage pattern. Instead of that clean, predictable path up to the periaortic nodes, you suddenly introduce a secondary contaminated drainage pathway directly to the inguinal nodes in the groin.
Which means your treatment field just got a lot bigger and more complicated.
Way more complicated. You've potentially upstaged the patient's disease locally and made their necessary surgery more complex and possibly less successful just by trying to confirm the diagnosis.
So the risk of violating that lymphatic integrity vastly outweighs the tiny chance that you might be operating on a very rare, benign intratesticular mass.
Exactly. The diagnostic step and the therapeutic step become one and the same. Your clinical history, your exam, the ultrasound, and the tumor markers, that has to be enough to trigger the definitive management.
Which brings us directly to that management. Since we skipped the biopsy, the first surgical step is both diagnostic and therapeutic.
That's right. And the foundational procedure for all suspected cases is a high inguinal orchidectomy.
Explain the high inguinal part. Why the groin incision instead of operating directly on the scrotum where the mass is?
The high inguinal incision is essential because it lets the surgeon get control of the spermatic cord, the vessels, the lymphatics, high up in the groin before they even touch the tumor.
So you can clamp everything off first.
You clamp and ligate the cord structures early. This minimizes the chance of malignant cells being squeezed out and spreading during manipulation of the testes.
It maintains that clean anatomical plane.
It does, and it reinforces that absolute rule. No scrotal incision is permitted. You approach from above, never directly through the scrotum.
So the excised testes goes to pathology, And the results then determine what happens next. Let's start with seminoma.
Seminoma is the relatively good news diagnosis. Its key characteristic is that it is highly radiosensitive and chemosensitive.
So for an early-stage seminoma, what's the post-surgery management?
For stage I, where the disease is confined to the testes, management is often driven by surveillance, just regular monitoring of markers and scans.
Because the cure rate is so high already.
It is, 95 to 98%. But for patients who might not be great at long-term surveillance, a single dose of adjuvant chemotherapy, usually carboplatin, might be considered.
And if the disease is more advanced, with positive nodes,
Then the intensity escalates. Because it's radiosensitive, radiotherapy to the retroperitoneum is highly effective. Or, for more bulky disease, chemotherapy based on agents like cisplatin. The prognosis is still excellent.
now let's compare that to the non-seminomatous germ cell tumors, the NSGCTs.
NSGCTs are generally more aggressive, they have a higher metastatic potential and grow much faster, so their management is typically more intensive, even in early stages.
And how does that translate into the role of chemotherapy?
Chemotherapy is the absolute backbone for disseminated NSGCTs. Even in a high-risk stage I, chemo might be initiated right away. For more advanced disease, you're looking at aggressive, multi-agent regimens.
And this is where that other major surgery might come into play, the retroperitoneal lymph node dissection, or RPLND.
Right. RPLND is a very significant, complex surgery. Its role is twofold. Sometimes it's done up front, but more commonly, it's performed to remove residual masses after chemotherapy has killed the active cancer cells.
Why remove a mass if the chemo has already worked?
Because NSGCTs are tricky. Chemo might shrink the tumor but leave behind viable cancer cells, or just scar tissue, or, and this is crucial, viable teratoma elements.
And teratomas are chemo-resistant.
Highly chemoresistant. So the RPLND physically removes that residual mass to prevent a recurrence or transformation down the line.
And the complexity of that surgery goes right back to the anatomy we started with, operating around the aorta and vena cava.
It does. It's technically very demanding. And one of the common side effects, which is so important for quality of life in these young men, is potential disruption of nerves controlling ejaculation. It's a high-stakes decision.
And just to complete the loop, what about those minority non-germ cell tumors?
As we said, they're usually benign. So for Leydig and Sertoli cell tumors, that initial high inguinal orchidectomy is almost always curative. No further intensive therapy needed.
Okay, so after the definitive treatment, the surveillance phase begins. Given the young age of these patients and the risk to the other testes, what's the core follow-up protocol?
Long-term surveillance is absolutely non-negotiable. It can extend for 10, even 15 years. And the cornerstone remains the regular monitoring of those three tumor markers, AFP, beta-HCG, and LDH.
Because a rising marker is the most sensitive signal of recurrence.
It is the earliest red flag, and this is complemented by scheduled imaging CT scans of the chest, abdomen, pelvis, with the frequency decreasing over time.
This brings us to the prognosis, and this is the really powerful context here. We started by saying, this is highly curable. Let's really emphasize that outcome.
The prognosis is just tremendously positive. The sources explicitly stated as one of the most curable solid malignancies in modern oncology. Even in cases with widespread metastatic disease, cure rates often exceed 80% with modern chemo.
That is a phenomenal success story. But we have to reiterate the condition that makes it possible.
One last time. Early detection is key. That is the thing that maintains that high cure rate. Stage I disease is almost universally curable, often with just the surgery. Delayed diagnosis means more aggressive treatment, more morbidity, and slightly lower cure rates.
So let's summarize the absolute necessities for a successful clinical approach, consolidating all these high-yield facts.
Okay, let's do a checklist. Number 1, maintain a high index of secretion for any painless hard mass in a young man.
Number 2,
Conduct a proper systematic examination, remembering to check the abdomen, supraclavicular nodes, and for gynecomastia.
Number 3, the big one.
Adhere to the absolute rule, no biopsy through the scrotum, ever. Protect the lymphatics.
Number 4,
Ensure early high inguinal orchidectomy as the combined diagnostic and therapeutic first step.
and finally, number 5.
Provide appropriate multimodal treatment after surgery, tailored precisely to the histology seminoma versus NSGCT and the stage.
That is a powerful structured summary. You've really given the listener the confidence to not just recognize the danger, but to know the exact path forward.
And it leaves us with that final aphorism that just encapsulates the entire discussion.
We're
Early diagnosis turns testicular cancer into a curable disease.
Before we wrap up, there's something you said earlier about the risk to the contralateral testis. Survivors face decades of surveillance.
They do. And this high-risk population leads to an important, maybe provocative question for you, the listener, to consider.
Okay.
Since these tumor markers are such incredibly sensitive tools for detecting recurrence, should we be pushing for their use, maybe with an annual ultrasound, as a routine screening protocol for all high-risk asymptomatic individuals?
So you mean people with a history of cryptorchidism or a strong family history?
Exactly. The challenge is balancing the benefit of catching a stage eye recurrence versus the anxiety and cost of frequent screening. But, optimizing that surveillance for the high-risk group is a really compelling area of research.
That's a great thought. It leverages the power of those markers beyond just the post-treatment phase. Thank you for sharing your sources for this deep dive. The logical next step, it seems, is to apply this structured approach more broadly.
Correct. The suggested path forward is to integrate all of this benign and malignant conditions and focus on a structured, systematic approach to all scrotal swellings.
So you ensure that when that rare malignancy does present, it's not missed among the much more common things like hydroceles and infections.
That's the goal.
That sounds like a fascinating conversation for next time. Thank you for joining us on the deep dive. We hope this has provided you with the confidence and structure needed to tackle this crucial clinical scenario.